Okay, let's open up this fascinating topic. Welcome to the Deep Dive, the show where we take a stack of information articles, research our own notes, and really extract the most important nuggets of knowledge or insight, giving you a real shortcut to being incredibly well-informed. Today, we're taking an intensive look into a subject that touches many lives, often without them even realizing it. Supraventricular tachyarrhythmias, or SVTs.
Right.
Our mission today is to truly understand this information with the depth and clarity typically possessed by the most seasoned professionals in the medical field. Really master it.
Precisely. And we're going to dive deep into complex medical concepts, drawing primarily from Chapter 246 of Harrison, which is, well, a foundational text, widely recognized in internal medicine for its comprehensive insight.
Gold standard, really.
Absolutely. So our goal isn't simply to define terms or list symptoms. It's to build a robust understanding of the intricate electrical mechanisms that drive these arrhythmias, their real-world clinical implications for patients, and the subtle diagnostic nuances that can often make all the difference. This really raises an important question, doesn't it? How do we move beyond just memorization to a level of core understanding, true mastery?
And that's exactly the journey we're taking you on today. At a high level, SVTs are about heart rhythms that are too fast.
So fast.
Yes, but specifically it's about where these rapid rhythms originate in the heart. That's the key part. So we're going to walk you through the broad categories of SVTs, then really drill down into the very specific types.
We'll explore how they're diagnosed, using everything from traditional ECGs to, well, the cutting-edge devices many of us wear every day now.
Oh, those watches and things.
Exactly. And then detail the critical initial steps taken when someone is experiencing one.
So by the end of this deep dive, you'll possess a truly elevated understanding of this common, yet often misunderstood area of cardiology. Okay, let's lay the groundwork right from the start. When we talk about supraventricular tachycardia, what exactly are we referring to? And that term, supraventricular, it seems to be giving us a big clue about where the problem lies, doesn't it?
It absolutely is. The name supraventricular tachycardia is really a roadmap in itself.
Okay.
SVTs are a broad category of common cardiac arrhythmias, meaning disruptions to the heart's normal electrical rhythm that are defined by their anatomic origin.
The origin?
Yes. They originate from or are dependent on electrical activity passing through the atrium, which is the heart's upper collecting chamber, or the atrioventricular node, the AV node.
The gateway.
That's a good way to put it. It's a crucial electrical gateway between the upper and lower chambers. This electrical activity then quickly conducts down to the ventricles, the heart's main pumping chambers.
I see.
So supraventricular literally translates to above the ventricles.
Right.
It immediately tells us that the electrical problem causing the rapid heart rate is located either in the atria or at the AV node.
So clearly distinguishing them from arrhythmias originating in the ventricles?
Exactly. Ventricular arrhythmias are a whole different ballgame. This localization above the ventricles is the first critical piece of the diagnostic puzzle.
So it's a critical geographic marker for the heart's electrical system. If the problem is consistently originating above the ventricles, what does that typically mean for its visual signature on an ECG, an electrocardiogram? Is there a characteristic pattern they look for?
There is, yes, and it's one of the most fundamental diagnostic features. Most SVTs produce what we call a narrow QRS complex tachycardia.
Narrow QRS.
On an ECG, the QRS complex represents the rapid electrical activation that leads to the contraction of the ventricles, the big pump. In SVTs, this QRS duration is typically less than 120 milliseconds. So quite fast, quite narrow.
Less than 120 meters.
Right, 120 meters.
Right.
This narrow appearance is incredibly important. It signifies that the electrical signal is traveling down the heart's normal, highly efficient Purkinje system.
Ah, the normal wiring.
Precisely. The heart's specialized wiring network. It's designed to distribute electrical impulses rapidly and synchronously throughout the ventricles, ensuring they contract in a coordinated, effective manner.
Makes sense.
That's exactly why SVTs are often referred to as narrow complex tachycardias.
Okay.
And what's also a crucial diagnostic clue for clinicians is that the overall shape, the morphology of the QRS complex during an SVT episode usually remains identical to the QRS morphology seen during normal sinus rhythm.
So it looks the same as when the heart's beating normally, just faster.
Exactly, which provides strong assurance that despite the rapid rate, the ventricles themselves are being activated and contracting in their usual healthy way.
That makes the narrow QRS sound like a relatively good sign then, in context.
Relatively, yes. It suggests the main highways are working.
But I've certainly heard of wide QRS rhythms, and that often carries a much more serious connotation. This sounds like where it gets really interesting and potentially very tricky for clinicians. How do you distinguish a wide QRS that's still an SVT from something far more dangerous, like ventricular tachycardia, VT, originating in the lower chambers? This feels like a high-stakes diagnostic challenge.
You've absolutely hit on one of the most critical and, frankly, sometimes terrifying distinctions in acute cardiology.
I can imagine.
It can absolutely be a matter of life and death. Misdiagnosis here can have immediate and severe consequences.
Wow.
While it's true that the vast majority of SVTs present with a narrow QRS, there are specific, crucial situations where an SVT can produce a wide QRS complex.
Okay, how?
Well, it can occur due to something called aberrancy.
Aberrancy.
Yeah, it basically means there's a transient rate-related conduction block in one of the heart's main electrical branches, like the left or right bundle branch. The signal gets slowed down temporarily on one side.
Ah, temporary detour.
Sort of. Or, and this is even more critical, if the activation of the ventricles occurs via an accessory pathway.
That bypass tract we talked about.
Exactly, that abnormal extra-electrical connection that completely bypasses the normal AV node.
Right.
So when an SVT presents with a wide QRS, it must, without exception, be distinguished from ventricular tachycardia, VT.
Must. Okay. Why is that distinction so paramount?
Because the treatment approaches are profoundly different. Ventricular tachycardia, originating directly from the lower heart chambers, is inherently more unstable. It's far more prone to degenerating rapidly into ventricular fibrillation.
Which is cardiac arrest.
Which is cardiac arrest, chaotic, non-pumping rhythm. So the medications, the pacing, the immediate electrical cardioversion required for VT, they're entirely different from those for a wide complex SVT.
You can't treat them the same way.
Absolutely not. Misdiagnosing a wide complex SVT as something less dangerous, or even worse, treating a life-threatening VT as if it were a benign SVT.
Why?
Well, that could directly lead to catastrophic outcomes. It's a moment where a clinician's mastery of ECG interpretation is truly tested. It demands precise and often urgent intervention. The ability to differentiate these two, sometimes in seconds, is a hallmark of expert cardiac care.
Okay, so we've pinpointed what SVTs are and how their ECG signature, especially that QRS width, is so critical. Narrow, usually okay. Wide, very tricky.
Right, that's a good summary.
Now, let's dig into the how do these rapid heart rhythms actually happen? Our source material, Harrison, it breaks down the underlying mechanisms into two fundamental categories, right?
That's our next critical step, yes. Because understanding the underlying mechanism isn't just academic interest. It's fundamental to both accurate diagnosis and, importantly, effective targeted treatment.
Makes sense.
So we broadly classify the mechanisms of these supraventricular tachyarrhythmias into physiologic sinus tachycardia and pathologic tachycardia. Table 2461 in Harrison details this really well.
Physiologic versus pathologic. Okay. What's the difference?
The physiologic type is essentially a perfectly normal, appropriate response of the heart to some stimulus.
Like exercise.
Exactly. Vigorous exercise or experiencing acute stress, maybe a fever. Your heart rate naturally and appropriately increases. That's usually physiologic sinus tachycardia.
So the heart's just doing its job.
Precisely. It's not a malfunction. It's the body's healthy, adaptive response to meet increased demands or counteract a threat. It doesn't indicate an intrinsic electrical problem within the heart itself.
Okay, so what about pathologic then?
In stark contrast, pathologic tachycardia implies there's an inherent electrical problem, a malfunction within the heart's conduction system that causes the rapid rate, independent of any normal physiological trigger.
Ah, so this is the real glitch.
This is the glitch. This distinction is truly a fundamental branching point for diagnosis because obviously your approach to managing a normal physiological response is vastly different from treating an electrical short circuit or a faulty pacemaker cell within the heart. That makes perfect sense. One is the body working right. The other is an actual electrical problem. Let's really drill down into the pathologic side now because that's where the diagnostic puzzle truly begins. The source further subcategorizes these problematic arrhythmias. What are the main mechanical pathways, the different ways these electrical glitches manifest?
Right. For pathologic tachycardias, we typically delve into three primary mechanical pathways. Each represents a distinct electrical problem or, as you said, a short circuit within the heart.
Pathway one.
First, we have reentrant arrhythmias dependent on AV nodal conduction. The classic example here is AV nodal reentry tachycardia, or AVNRT.
AVNRT, got it.
In this scenario, the heart's electrical signal gets trapped in a continuous short circuit within or immediately around the AV node itself.
Like an electrical loop.
Exactly. Instead of the impulse just passing through the AV node and moving on to the ventricles, a portion of the signal loops back on itself, creating this perpetual rapid electrical loop that drives the fast heart rate.
Like getting stuck in a roundabout.
That's a great analogy, a very tight, continuous loop.
Okay, foreground pathway.
Second, we encounter large reentry circuits within the atrial tissue alone. Atrial flutter is the classic example here.
Ventricular flutter.
Unlike AVNRT, which is localized to the AV node, atrial flutter involves a much larger organized electrical loop. It's typically confined within the atria, most commonly the right atrium.
So a bigger circuit just in the upper chambers.
Right. And critically, the sustainment of this rapid atrial activity is entirely independent of the AV node. The AV node just acts as a passive filter, transmitting only some of these rapid signals down to the ventricles. You can visualize it as an electrical impulse perpetually chasing its tail around a defined, larger racetrack within the upper chambers.
Okay. And the third type.
And third, we have focal atrial tachycardias. These are quite distinct. They originate from a single, isolated hotspot or discrete area within the atrium.
A hotspot.
Yeah, it's not part of a large circuit. It can either be firing rapidly and spontaneously due to what we call automaticity.
Automaticity, meaning?
Meaning cells in that area are intrinsically generating electrical impulses at an abnormally high rate, like a faulty, overactive spark plug.
Oh.
Or it can be a very small, localized reentry circuit, much smaller and more contained than the macroentry of atrial flutter. It's an independent, singular source of rapid electrical discharge.
So AZ node reentry, large atrial reentry like flutter, or a focal hotspot. Those are the main pathologic mechanisms.
Those are the three big categories, yes.
It sounds like the prognosis and, perhaps more critically, the treatment for these different types would vary widely based on their specific mechanism. Why is understanding that precise underlying mechanism so absolutely crucial for the patient, for their well-being and long-term management?
Oh, it's not just crucial. It's the very foundation of effective cardiac care for these conditions. The root cause, the specific electrical malfunction, directly dictates how a patient will be managed. Everything from the medications they receive to the specific procedural interventions that might offer a cure.
Can you give an example?
Sure. Consider AVNRT, that reentrant circuit, involving the AV node. Medications designed to slow or block conduction through the AV node-like adenosine, which we'll talk more about, or beta blockers, are often highly effective in stopping the episode.
Right.
And remarkably, a highly targeted procedure called catheter ablation can offer a permanent cure by precisely destroying that small, specific short-circuit pathway.
Wow, a cure.
Often, yes. Now, contrast that with atrial fibrillation, that chaotic, disorganized electrical activity. Here, the treatment focuses not just on controlling the heart rate, but also critically on managing the significant risk of stroke.
Because of blood clots.
Exactly. Blood can pool and form clots in the fibrillating atria. So the prognosis, the choice of antiarrhythmic drugs, the decision for ablation, it's an entirely different conversation tailored to the chaotic nature and the stroke risk.
I see.
Similarly, atrial flutter, with its large organized pathway, might be highly amenable to ablation of its specific circuit, often offering a very good long-term prognosis.
So if you don't know the mechanism,
You're essentially flying blind, or at best, just reactively managing symptoms. The more precisely you identify the mechanism, the more tailored, effective, and often curative the treatment can be. It significantly improves quality of life, reduces symptoms, and prevents potentially serious complications. It's really the difference between guessing and knowing.
that explanation of mechanisms really clarifies how diagnosis drives treatment. Now, the source also highlights different durations for these arrhythmias. That was heavily influenced the urgency in management too, right?
Absolutely.
What's the clinical distinction between non-sustained and sustained SVT, and why does that distinction matter so profoundly for the patient?
The duration is another fundamental piece of information. It speaks directly to the arrhythmia's severity and persistence. Non-sustained SVT refers to episodes that are brief,
How brief?
typically lasting less than 30 seconds. And crucially, they are almost always self-terminating.
They stop on their own.
Yes, the heart returns to its normal rhythm spontaneously, without any medical intervention. Now, these brief episodes can still cause concerning symptoms like palpitations and be quite alarming for the patient,
Sure.
but their self-limiting nature generally means they pose less immediate danger. They might not require urgent treatment to stop the episode itself. Management often focuses more on preventing future episodes.
Okay. So what about sustained?
In contrast, sustained SVT is an arrhythmia that persists for a longer duration, generally more than 30 seconds, or, more importantly, it requires an active medical intervention for its termination.
It needs help to stop.
Exactly. And help to maintain a normal sinus rhythm afterwards. This intervention could range from vagal manoeuvres, which we'll get
Okay.
to medication administration, or even more aggressive measures like electrical cardioversion or catheter ablation. The distinction matters profoundly because if an SVT is sustained, it's not going to resolve on its own.
It's stuck.
It's stuck. The patient will continue to experience rapid heart rates and symptoms until medical intervention is provided. This naturally indicates a higher level of clinical urgency and a greater need for immediate medical attention.
So if it's sustained, it's not letting go without a fight demanding intervention.
Oh.
Okay. And then there's paroxysmal. What does that term specifically mean for the patient experiencing it? Is it just a recurring sustained SVT?
Good question. The term paroxysmal refers specifically to the characteristic way an episode begins and ends. It implies a sudden onset and an equally sudden termination.
Abrupt on off.
Exactly. So while a paroxysmal SVT episode can indeed be sustained, meaning it requires intervention to stop, the hallmark feature is that abrupt on-off nature. Imagine your heart rate suddenly, literally in an instant, jumping from a normal 70 beats per minute up to 180.
Whoa.
And then, just as abruptly, dropping back to normal. This sudden, unprovoked change is what makes it paroxysmal.
That must feel very strange.
It can be profoundly alarming and distressing for patients, even if they don't have severe symptoms otherwise. Patients often vividly describe feeling a sudden flip-flop, a lurch, or a thump in their chest right at the onset or termination.
I can see why that's alarming.
And importantly, paroxysmal supraventricular tachycardia, PSVT, isn't a single unique type of arrhythmia. It's more of a clinical descriptor for a family of tachycardias that share this paroxysmal characteristic.
Ah, okay. It's a category based on behavior.
Exactly. As our source highlights, this family includes common types like AV node reentry, AVNRT, AV reciprocating tachycardia using an accessory pathway, AVRT, and certain types of focal atrial tachycardia. Figure 246:1 in Harrison visually guides clinicians through these, showing how these distinct mechanisms can all manifest with that signature sudden onset and termination.
So PSVT is less about the mechanism and more about the presentation, this sudden start and stop.
You've got it. It's about that striking, abrupt clinical behavior.
Understanding the timing and mechanisms is vital for clinicians, for sure. But for someone actually experiencing an SVT, their most immediate question is usually, what am I feeling?
Yeah.
So for a person having an SVT, what are the common symptoms they might present with? How does it feel?
That's a critical bridge from the science to the patient experience, and the clinical symptoms are remarkably diverse. Their severity can vary significantly from person to person, even with the same underlying SVT type.
What does it depend on?
Several key factors. The actual rate of the tachycardia itself, how long the episode lasts, whether the patient has any associated underlying heart disease, and any other coexisting medical conditions, comorbidities.
Okay. But what are the most common feelings?
The most common symptom, often the primary reason someone seeks medical attention, is palpitations.
Palpitations, meaning?
Often described as a racing heart, a sensation of pounding in the chest, or a disconcerting fluttering feeling.
Okay. Anything else?
Beyond palpitations, patients might experience chest pain. This can be particularly alarming, as it can sometimes be mistaken for a heart attack,
Right.
especially if the rapid heart rate is causing the heart muscle to work excessively hard and not get enough oxygen.
Makes sense.
Dyspnea, or shortness of breath, is another frequent complaint. The heart's pumping efficiency can be significantly reduced at very high rates, leading to inefficient blood circulation.
Difficulty breathing.
Yes. Some individuals report diminished exertional capacity, meaning they get tired much more easily than usual, even with minimal physical activity. Their heart just can't keep up with supplying oxygenated blood.
Feeling wiped out easily.
Exactly. And occasionally, if the heart rate becomes extremely fast and compromises blood flow to the brain, patients may experience syncope.
Fainting,
yes. A temporary loss of consciousness. Generally, the faster the heart rate and the longer the arrhythmia lasts, the more severe the symptoms tend to be. But again, the underlying health of the heart plays a massive role in how well someone tolerates these episodes.
Okay. So mostly palpitations, maybe chest pain, shortness of breath, fatigue, rarely fainting. Sounds concerning, but maybe not immediately life-threatening for most.
No, that's true.
But the source does mention something far more dire: cardiac arrest. When does an SVT, which we typically think of as originating above the ventricles and maybe less dangerous, become truly perilous, capable of precipitating cardiac arrest? This feels like the so what for certain high-risk patients.
You've highlighted a critical, albeit rare exception that every clinician must be acutely aware of. While the vast majority of SVTs are not immediately life-threatening, a supraventricular arrhythmia can indeed precipitate sudden cardiac arrest in specific high-risk patient populations.
Like who?
The most prominent example from our source is patients with Wolff-Parkinson-White WPW syndrome.
WPW, that involves the accessory pathway, right?
Exactly. Or patients with severe underlying structural heart disease, such as hypertrophic cardiomyopathy. This is where those electrical pathway intricacies become a matter of life and death.
How does WPW lead to cardiac arrest from an SVT?
In WPW, patients have that accessory pathway, that abnormal extra electrical connection, linking the atria and ventricles, critically bypassing the normal protective delay of the AV node.
Bypassing the gatekeeper.
Precisely. Normally, the AV node slows down rapid atrial impulses, preventing the ventricles from beating too fast. But if an atrial arrhythmia, particularly atrial fibrillation, that chaotic, extremely rapid atrial activity, develops in a WPW patient,
Oh, no.
the electrical impulses can conduct directly and very rapidly down this accessory pathway to the ventricles. Unlike the AV node, this accessory pathway has no protective delay. It can conduct impulses at dangerously fast rates,
How fast?
sometimes exceeding 250 or even 300 beats per minute to the ventricles.
Wow.
This extreme, uncontrolled ventricular rate can cause the ventricles to simply quiver ineffectively, ventricular fibrillation, instead of pumping blood,
Which is cardiac arrest.
which is cardiac arrest.
Yeah.
That's the single most dangerous scenario for an SVT.
Okay. And the other group, hypertrophic cardiomyopathy.
Similarly, in patients with severe underlying structural heart disease like hypertrophic cardiomyopathy, where the heart muscle is abnormally thick and stiff, already struggling to pump effectively, even a rapid SVT that might be well tolerated in a healthy heart can overwhelm an already compromised heart.
Pushing it over the edge.
Exactly. It can lead to a profound drop in blood pressure, precipitate or worsen acute heart failure, or, in the worst cases, trigger lethal ventricular arrhythmias and cardiac arrest.
So this underscores the importance of identifying underlying conditions.
Absolutely. It dramatically transforms the risk profile of an SVT, elevating it from manageable to potentially catastrophic for certain groups. That's why a thorough initial evaluation is so fundamentally crucial.
That explanation of severe presentations really clarifies the stakes. Okay, so if someone suspects they might be experiencing an SVT, or if a doctor is considering it, how do they actually figure it out? Where does this crucial journey to a precise diagnosis begin? What are the primary tools?
The journey to diagnosing an SVT most often begins when a patient presents with those arrhythmia-related symptoms we discussed: palpitations, maybe dizziness, or sometimes, quite unexpectedly, during a routine outpatient ECG.
A routine checkup.
Yeah, it might show evidence of something called ventricular pre-excitation. But the absolute cornerstone, the primary detective, the first and most critical tool in this diagnostic process, is the electrocardiogram, ECG.
The ECG.
And it's truly crucial to obtain an ECG at the very moment the patient is experiencing symptoms.
Catch it in the act.
Exactly. Because if the arrhythmia is transient, comes and goes, and has already resolved by the time they get to the doctor or the ER, well, you won't capture the abnormal electrical activity causing the problem. You need that snapshot during the event.
You mentioned ventricular pre-excitation, showing up on a routine ECG as a clue. What exactly does that term mean, and what signature does it leave on the ECG? Is it a distinct pattern?
Yes, ventricular pre-excitation is a very specific and telltale sign on a resting ECG. It literally means the ventricles are being activated earlier, pre-excited, than they would be normally.
Earlier than usual.
Right, earlier than if the signal were traveling exclusively through the normal, more controlled AV node and Purkinje system pathway. This pre-excitation strongly suggests the presence of an accessory pathway.
The WPW thing again.
Often, yes. That abnormal extra electrical connection between the atria and ventricles that bypasses the AV node. It's the hallmark of conditions like Wolff-Parkinson-White syndrome.
What does it look like on the ECG trace?
It often manifests as a characteristically short PR interval, meaning the delay between atrial and ventricular activation is shorter than normal, and a distinctive delta wave.
Well, delta wave.
Yeah, it's a slurred, slow upstroke at the very beginning of the QRS complex. It basically indicates the electrical signal is taking that rapid shortcut directly into the ventricular muscle, leading to this early, somewhat disorganized activation.
So seeing that delta wave is a big red flag.
It immediately raises a red flag, yes. It alerts the clinician to the possibility of AV reciprocating tachycardia, a common SVT type that specifically uses this accessory pathway.
Okay, so what if the arrhythmia is happening right then and there? You get the person hooked up to a 12-lead ECG. Is that usually enough to nail down the diagnosis or at least point very strongly towards it? Is the ECG the gold standard in that acute moment?
Absolutely. When the arrhythmia is actively ongoing at the time the ECG is recorded, the ECG usually, almost unequivocally, establishes or strongly suggests the specific diagnosis.
Catching the culprit red-handed.
Exactly.
Yeah.
It gives you direct, undeniable evidence of the abnormal electrical activity. The intricate patterns of the P waves, the QRS complexes, their precise timing relationship, the heart rate, the rhythm regularity, it provides a wealth of information.
So an experienced eye can read a lot from that trace.
Oh, yes. An experienced clinician can meticulously analyze these patterns to identify the specific type of SVT, often down to its underlying mechanism.
But what about those fleeting paroxysmal arrhythmias you mentioned, the ones that come and go? Or if someone isn't having symptoms right when they're at the doctor's office, how do you catch those elusive events?
That's a very common and often frustrating scenario for both patients and clinicians. For those transient arrhythmias, or if symptoms are infrequent and unpredictable, an ambulatory ECG recording is absolutely warranted.
Like a Holter monitor.
The Holter monitor is the most well-known example, yes. It's a portable device that continuously records the heart's electrical activity, typically for 24 to 48 hours, sometimes even longer for very rare events.
So it monitors you during normal life.
Exactly. It allows clinicians to capture the arrhythmia if and when it occurs during the patient's normal daily activities, providing that crucial diagnostic snapshot that might otherwise be missed.
And what about newer tech, those smartwatches?
That's what's truly fascinating here, especially from the perspective of modern medicine and patient empowerment. The role of consumer-grade health technology is rapidly increasing. Many patients now have access to their own ECG recording devices, smartwatches with ECG functions, or small smartphone-enabled electrode pairs they can hold.
So people can record their own ECGs?
Yes. This means a patient might actually obtain a diagnostic quality ECG tracing before even seeing a physician. It's completely revolutionizing the traditional diagnostic workflow.
That's a huge shift.
It's profound. It empowers patients to be incredibly active participants in their own diagnosis, providing crucial, real-time data that might otherwise be elusive. It really raises interesting implications for how diagnostics might evolve. Initial screening, even preliminary diagnosis happening outside traditional clinics, it changes the whole dynamic.
Absolutely. Okay, are there any other, maybe more advanced tests needed beyond the ECG, especially if things are still unclear, or if you need to really pinpoint the problem or assess risk more deeply?
Yes, definitely. While the ECG is foundational, other evaluations are often performed to get the full picture.
Such as?
First, exercise testing is often valuable. The parent exercises, usually on a treadmill or bike, while hooked up to an ECG.
A stress test.
Right. It serves a dual purpose. Assessing if symptoms are related to exertion, and crucially, it can potentially evoke the arrhythmia, reveal it under stress conditions.
Provoke it to diagnose it.
Sometimes, yes. Second, a broader evaluation for underlying cardiac disease is always paramount. Based on the clinical scenario, additional tests like an echocardiogram,
An ultrasound of the heart.
exactly, visualizes structure and function, or other advanced cardiac imaging might be done. The goal here is to exclude any potentially dangerous underlying heart conditions, structural abnormalities, cardiomyopathies that could significantly impact the risk and management of the SVT.
Checking the heart's overall health.
Right. Any abnormal findings warrant further, deeper cardiac evaluation. Safety first.
Makes sense. And what's the most advanced test?
Finally, in specific complex situations, an invasive electrophysiology study, EPS, is warranted.
Invasive. Yeah. Sounds serious.
It's a much more specialized procedure. Thin, flexible wires, catheters, are threaded through veins, usually in the groin, and guided directly into the heart. These catheters can precisely map the heart's intricate electrical activity. They can deliver controlled electrical impulses to provoke the arrhythmia in a controlled environment, definitively confirm its exact mechanism, and risk stratify the patient, assess their risk for more dangerous events.
So it's mapping and testing the wiring directly.
Precisely. And most commonly, an EPS isn't just for diagnosis alone. It's often performed at the same time as an intended catheter ablation.
The treatment procedure.
Yes. If the arrhythmia is successfully provoked and meticulously mapped, the same catheters can then deliver energy like radiofrequency heat or cryoablation cold to precisely destroy the problematic electrical pathway, offering a definitive cure for many SVTs.
So EPS is usually done when you're already considering ablation?
Generally, yes. It's reserved for situations where definitive treatment is being considered due to persistent symptoms or a high-risk profile.
Okay, so we've navigated that complex diagnostic journey, from ECGs to wearables to invasive EPS studies, all to pinpoint the specific SVT. Now, let's pivot to action. Once an SVT is identified, what happens next? Especially in an urgent situation, patient symptomatic, distressed. What are the first things clinicians try to do to get that runaway heart rate under control?
Right. Once an SVT is suspected or confirmed, the initial assessment and treatment strategy are fundamentally guided by the patient's clinical stability. How are they doing right now?
Okay.
The very first step, which is often crucial and can prevent unnecessary interventions, is to consider the possibility of physiologic sinus tachycardia.
Back to that normal response.
Exactly. As we discussed, it's the most frequent type of SVT, just a normal, albeit rapid, response to stress, exercise, illness, pain, anxiety, fever.
So rule that out first.
Yes. If the diagnosis points definitively to sinus tachycardia, then the treatment isn't directed at the heart rhythm itself. It's entirely aimed at addressing and resolving the underlying inciting cause.
Treat the fever, manage the pain.
Exactly. Address the root cause, and the heart rate will naturally normalize.
Okay. But what if it's not physiologic? What if it's a true pathologic SVT happening right now?
Right. If the arrhythmia is ongoing and it's clearly not physiologic sinus tachycardia, the immediate assessment shifts. Does this patient need prompt therapy to terminate the arrhythmia or at least significantly slow the rate?
When is immediate therapy definitely needed?
It's absolutely warranted and often life-saving if the arrhythmia is causing signs of hemodynamic instability. Meaning if the patient is experiencing hypotension, dangerously low blood pressure, impaired consciousness, profound dizziness, confusion, near fainting, angina, chest pain indicating heart muscle oxygen starvation, or if the rapid rate is actively precipitating or worsening heart failure symptoms.
So if they're really unwell because of the fast rate.
Precisely. In these critical situations, interventions are guided by the specific type of arrhythmia and the patient's overall condition, with the overarching goal of rapid stabilization.
So, if it's an emergency, what are those immediate frontline therapies? I've heard of vagal manoeuvres. How do they work? They sound deceptively simple.
You're right, they can seem simple, but their physiological impact is quite profound. In urgent care or inpatient settings, the initial treatment for many SVTs, especially those involving the AV node in their circuit, often involves vagal maneuvers or carotid sinus massage, CSM.
How do they work?
They leverage the body's own nervous system. They work by stimulating the vagus nerve.
The vagus nerve, part of the rest and digest system.
Just exactly, the parasympathetic nervous system. When stimulated, the vagus nerve releases neurotransmitters that act on the AV node, effectively slowing down its electrical conduction and increasing its refractory period, making it less responsive to rapid impulses.
So it pumps the brakes on the AV node.
That's a good way to think of it. This crucial slowing or transient blocking of conduction through the AV node can often interrupt the reentrant circuit of an SVT, terminating the arrhythmia.
Okay. What are some examples? The source mentions a few.
Right. Table 246-2, and the figures detail several illustrative vagal maneuvers. The Valsalva maneuver is very common. Holding your breath and bearing down forcefully, like straining.
Oh.
This increases intrathoracic pressure, which indirectly but powerfully stimulates the vagus nerve.
Right.
A modified Valsalva might involve breathing hard into a syringe against pressure, aiming for more controlled stimulation.
Yeah.
Another simple one is a rapid leg raise. Abruptly raising the patient's legs to 45 degrees increases venous return to the heart, which can trigger a reflex vagal response.
Interesting.
The diver's reflex, submerging the face in cold water, is a powerful vagal stimulus, though maybe less practical in some settings.
Yeah, maybe less comfortable too.
And finally, carotid sinus massage, CSM. A clinician gently massages the carotid sinus in the neck near where the carotid artery splits. This area is highly sensitive to pressure and signals the brain to increase vagal tone.
Gently massaging the neck artery.
Yes. But there's a crucial caution with CSM. It must be used very cautiously, maybe avoided entirely, if there's any concern for carotid atherosclerosis hardening of the neck arteries.
Why is that?
There's a small but significant risk that manipulating the carotid artery could dislodge a plaque, potentially causing a stroke.
Oh, wow. Okay.
So clinicians must always listen for abnormal sounds, bruits over the carotids, and assess stroke risk factors before trying CSM. Safety first, always.
That's a vital safety point.
Oh, okay.
If those vagal maneuvers, the immediate low-tech options, don't work to break the SVT, what's the very next step? I've heard a drug called adenosine. What does that do? How quickly does it act?
If vagal maneuvers are unsuccessful, the next rapid and highly effective step, especially in urgent settings, is the intravenous administration of adenosine.
Adenosine.
It's given very rapidly, typically a 6 or 12 milligram dose, immediately followed by a rapid saline flush. Its action is almost instantaneous. It has an incredibly short half-life metabolized by the body in mere seconds.
Seconds. Wow, what does it do?
Adenosine works by transiently causing profound AV block. It briefly, but powerfully, blocks electrical conduction through the AV node.
Like a very strong, very short brake pedal.
Exactly. And the outcomes of giving adenosine provide crucial diagnostic information. It's an indispensable tool.
How so? What are the outcomes?
Outcome 1. Termination of SVT. If the SVT is dependent on the AV node for its circuit-like AVNRT or AVRT, adenosine will almost always successfully terminate the arrhythmia. The temporary block disrupts the reentrant loop, letting the heart reset to normal sinus rhythm, often dramatically effective.
Stops it cold.
Often, yes. Outcome 2. Diagnosis of non-AV nodal-dependent SVT. If the SVT is not dependent on the AV node like atrial tachycardia or atrial flutter, adenosine will not terminate it.
Yeah.
However, it will still cause that transient AV block. It will temporarily slow the ventricular rate. And crucially, this allows the clinician to unmask and clearly see the underlying rapid atrial activity on the ECG.
So it reveals the hidden atrial rhythm.
Precisely. This visual unmasking is incredibly helpful for accurately differentiating atrial tachycardias and flutter from the AV nodal-dependent SVTs, which can look very similar when everything's conducting rapidly.
That's clever. So it treats and diagnoses.
It often does both. Now, there's a slight caveat from the source. Some focal atrial tachycardias are actually adenosine sensitive, meaning they can terminate with adenosine.
Exception.
A small exception. So while termination strongly suggests AV nodal dependence, it doesn't completely exclude all other possibilities, though it significantly narrows them down. But this remarkable dual-function swift therapy and powerful diagnostic tool makes adenosine a cornerstone drug in acute SVT management.
Okay, now that we covered those acute interventions, let's really get into the nitty-gritty of the different types of pathologic SVTs. Our source, Table 246-1 in Harrison, provides a fantastic, really detailed breakdown. Let's start with those originating specifically from the atrium, the upper chambers. Unpack their unique characteristics.
Excellent. The defining feature for this whole category, a tachycardias originating from the atrium, is key. The tachycardia may continue despite some impulses failing to conduct to the ventricles.
Meaning the AV node blocks some beats, but the atrial rhythm keeps going.
Exactly. This clearly indicates that the AV node is not a necessary part of the main tachycardia circuit. It's just a passive, bystander, or filter, transmitting as many impulses as it can based on its own refractory period.
Okay, so what's first in this atrial category?
Within this category, we distinguish, number 1, inappropriate sinus tachycardia.
Inappropriate sinus tachycardia. Sounds like the normal pacemaker gone wild.
Pretty much. It originates from the normal sinus node, the heart's natural pacemaker, but it occurs without an identifiable precipitating factor. Unlike physiologic sinus tach, where there's a reason, like exercise or fever,
Right.
here there's no obvious reason for the fast rate. It results from dysfunctional autonomic regulation. The body's internal heart rate control system is just miscalibrated, causing the sinus node to fire too fast.
Like the idle speed is set way too high.
That's a good analogy. Number 2, focal atrial tachycardia, AT.
Focal AT, the hot spot one.
Exactly. A regular atrial tachycardia with a well-defined P wave on the ECG, but originating from a single isolated hotspot or discrete electrical focus within the atria.
Can it be sustained? Or does it come and go?
It can be sustained, non-sustained, paroxysmal, or sometimes even incessant, meaning it almost never stops. a continuous, rapid atrial rhythm.
Where do these hot spots tend to occur?
The source highlights frequent anatomical sites along the valve annuli of the left or right atrium around the heart valves,
Okay.
within the pulmonary veins where blood enters the left atrium, often implicated in atrial fibrillation too,
Ah,
the musculature of the coronary sinus, and the superior vena cava. These are critical areas where aberrant electrical activity can arise due to enhanced automaticity or a tiny reentry circuit.
got it. What's next?
Number 3, atrial flutter and macro-reentrant atrial tachycardia.
Flutter, the big organized circuit.
Right. Characterized by macro-reentry, that large, highly organized electrical circuit within the atrial tissue, most commonly in the right atrium, circling the tricuspid valve annulus.
And it has that classic ECG look.
Yes, on an ECG, this organized atrial activity is reflected as classic, unmistakable sawtooth flutter waves, regular P waves, usually faster than 200 beats per minute, creating that distinct, undulating sawtooth pattern, a visual hallmark.
Okay, sawtooth waves and flutter.
Generally, yes. Number 4, atrial fibrillation.
Ah, AFib, the big one.
Arguably the most clinically significant and prevalent arrhythmia, a major public health concern, defined by chaotic, rapid, and completely disorganized atrial electrical activity.
So not organized like flutter.
Not at all. It results in a characteristically irregular and often rapid ventricular rate. Instead of organized contractions, the atria just quiver or fibrillate, generating a torrent of disorganized signals.
And that leads to the irregular pulse.
Exactly. Because these signals hit the AV node irregularly, the ventricular rate becomes highly irregular and often fast. Critically, this is the most common sustained cardiac arrhythmia in older adults, and it carries significant risks for stroke due to blood pooling and clot formation.
A major concern.
Absolutely. And finally, number 5 in this category, multifocal atrial tachycardia.
Multifocal, meaning multiple spots.
Precisely. As the name suggests, this involves multiple discrete P waves that vary significantly in their shape, their morphology. This indicates at least 3 different independent hot spots firing within the atria, each generating its own P wave.
So several different pacemakers competing.
In a way, this arrhythmia is frequently seen in patients with severe underlying pulmonary disease, especially during acute exacerbations of pulmonary insufficiency. Suggests a strong link between lung health and cardiac electrical stability in some people.
Interesting connection. Okay, that covers the atrial ones, clearly. What about those that involve the AV node directly, not just as a filter?
Yep. The primary example here, and a very common one, is BAV nodal reentry tachycardia, AVNRT.
AVNRT, again, the tight loop around the AV node.
Yes. It's a paroxysmal regular tachycardia with a very specific, almost signature ECG presentation. The P waves, representing atrial activity, are often visible at the very end of the QRS complex, or, crucially, they might not be visible at all.
Why aren't they visible?
Because they get buried within the QRS complex. This happens because the atria and ventricles are being activated almost simultaneously as the electrical impulse rapidly circles within the AV node itself using distinct fast and slow pathways.
They happen too close together to see separately.
Exactly. AVNRT is particularly significant because it's the most common paroxysmal sustained tachycardia in otherwise healthy young adults.
Healthy young adult.
Yes. What's fascinating and often alarming for patients is that this short circuit mechanism frequently affects people with absolutely no structural heart disease, no other underlying cardiac issues.
So it just pops up out of nowhere.
It can feel that way to the patient. Sudden, abrupt onset of a racing heart. In the source notes, it's more commonly diagnosed in women. So while it's an electrical glitch, it's often in an otherwise healthy heart. A very distinct clinical entity.
Okay. And finally, what about those really tricky ones that involve an accessory pathway? Those extra electrical connections. What defines these and what are the main types?
Yes, the C tachycardias associated with accessory atrioventricular pathways are indeed a crucial and at times dangerous group. As we touched upon, these pathways are like extra abnormal electrical connections shortcuts between the atria and ventricles, entirely bypassing the normal rate-limiting AV node.
The bypass tracks.
Right. This means electrical impulses can travel from atria to ventricles or sometimes from ventricles back to atria through these alternative routes, leading to complex reentrant tachycardias.
Okay. What are the main types here?
Within this category, we identify 2 main types, distinguished by the direction of electrical flow in the reentrant circuit. First, orthodromic AV reciprocating tachycardia, AVRT.
Orthodromic AVRT.
This is a very common paroxysmal sustained tachycardia. It can look quite similar to AVNRT on the ECG, often with a narrow QRS.
How is it different?
The key distinction is how the circuit works. The electrical impulse travels down through the normal AV node pathway to activate the ventricles, and then, crucially, travels back up to the atria via the accessory pathway, creating the loop.
Down the normal path, up the shortcut.
Exactly. Now, during normal sinus rhythm, evidence of ventricular pre-excitation, that short PR interval in the delta wave, may be present on the resting ECG. That's typical of Wolff-Parkinson-White WPW syndrome.
Where you can see the pathway even at rest.
Right. But sometimes the accessory pathway is concealed. It doesn't conduct impulses from atria to ventricles during normal rhythm, so no pre-excitation on the resting ECG. But it can still conduct from ventricles back to atria, allowing this orthodromic AVRT circuit to form.
Hidden but still usable for the tachycardia.
Precisely. The second main type is pre-excited tachycardia.
Pre-excited. This sounds like the wide QRS ones.
Exactly. This is a particularly concerning and diagnostically challenging category because it consistently presents as a wide QRS tachycardia. The QRS morphology can look frighteningly similar to ventricular tachycardia, VT.
The dangerous look-alike.
Yes, making it a critical diagnostic dilemma. Distinguishing it from VT is paramount. The wide QRS happens because the electrical impulse is traveling, at least partly, down the accessory pathway directly into the ventricular muscle. Bypassing the fast Purkinje system leads to slower, less synchronized ventricular activation, hence the wide QRS.
Okay. Are there subtypes of this pre-excited tachycardia?
Yes, several important subtypes. First, A, antidromic AV reciprocating tachycardia.
Antidromic, opposite of orthodromic.
Exactly. Regular paroxysmal tachycardia, but the signal travels in the opposite direction. Impulse goes down the accessory pathway first, then up the normal AV node pathway. Because it goes down the accessory pathway first, you get that wide QRS.
Down the shortcut, up the normal path. Okay.
Then B, atrial fibrillation with pre-excitation. This is extremely dangerous, potentially lethal.
The WPW and AFib combination we talked about.
Yes, presents as an irregular wide complex or intermittently wide complex tachycardia. Crucially, some can have dangerously rapid ventricular rates, over 250, even 300 beats per minute, because the accessory pathway conducts those rapid, chaotic AFib impulses directly and quickly to the ventricles, bypassing the AV node's protection.
It can lead to VFib and cardiac arrest.
Precisely. Hemodynamic collapse, ventricular fibrillation, sudden cardiac arrest. Identifying WPW and understanding the severe risk is absolutely paramount.
Critical. Any others?
And finally, C, atrial tachycardia or flutter with pre-excitation. Similar idea. If an organized atrial tachycardia occurs with a rapidly conducting accessory pathway, the rapid atrial rates can conduct quickly to the ventricles via the bypass tract, leading to a wide QRS attach and potential instability.
So understanding these accessory pathways is vital due to their potential for extremely rapid, unstable, wide complex rhythms.
Absolutely. The diagnostic challenge is immense, demanding meticulous ECG interpretation and swift clinical action.
That deep dive into these specific SVT types, especially those accessory pathway ones with wide QRS potential, really highlights the complexity and the critical need for precise diagnosis. It's clear clinicians rely heavily on specific ECG cues. Our source, Harrison, has those excellent flowcharts, like decision trees, that clinicians use. Let's break down how an ECG acts as that roadmap, helping clinicians narrow things down systematically.
Exactly. Figures 246-1 and 246-2 in the source are quintessential examples of these diagnostic algorithms, like a detective's guide for the heart's electricity. Let's start with figure 246-1, outlining the diagnostic possibilities based on the appearance of the 12-lead ECG during an SVT episode.
Okay, where does the algorithm start?
The starting point is identifying a narrow complex tachycardia. When a patient presents with this, the immediate action is getting a full 12-lead ECG with a long rhythm strip. Capture as much detail as possible.
Get the high-res photo.
Right. From there, the clinician faces a primary decision point. Is the atrial rhythm regular or irregular?
Okay, regular first. What are the possibilities?
If the atrial rate is regular, the possibilities narrow down to rhythms like junctional tachycardia, originating from the AV junction, AVNRT, the AV node short circuit, ORTT, orthodromic AV reentry, down normal up accessory, AT, focal atrial tachycardia, and rarely atrial flutter if there's a fixed AV conduction ratio, like a perfect 2.1 block.
Okay, and if the rhythm is irregular?
If the atrial and ventricular rates are irregular, the primary possibilities are atrial fibrillation, chaotic atrial activity, variable ventricular response, and multifocal atrial tachycardia, multiple P-wave shapes, inherently irregular.
So that first step, regular versus irregular, really splits the possibilities. What's next for the regular ones?
For the regular tachycardias, the next crucial step is assessing the AV conduction ratios or relationships. Clinicians look meticulously for VA block, more Vs than As, less common for typical SVTs; AV block, more As than Vs, common in flutter or AT, where the AV node blocks some rapid atrial impulses; or 1.1 AV response, every atrial beat followed by a ventricular beat, seen in many reentrant SVTs like AV-NRT or ORT.
And there was a subtle one.
Yes, rarely AV-NRT, with 2.1 block below the His bundle, a more advanced finding indicating a specific conduction disturbance.
So this structured approach systematically narrows down the options based just on ECG patterns.
Exactly. It's a roadmap for the electrical detective work leading to a precise diagnosis, avoiding missteps in crucial moments.
That's a fantastic illustration of the ECG as a blueprint. And then, once we try those vagal maneuvers or give adenosine, what does the heart's response tell us? This is where understanding the AV nodal blockade comes in, right? Building on that blueprint.
Absolutely. Figure 246.2, diagnostic effect of increasing atrioventricular AV node blockade, is the next critical real-time step, especially acutely. This flowchart beautifully illustrates how the heart's electrical response to interventions that transiently block the AV node vagal maneuvers, CSM, adenosine, verapamil, beta blockers, provides definitive, real-time clues about the mechanism.
Okay, so you block the AV node temporarily. What happens?
Several possible outcomes, each with profound diagnostic meaning. Outcome 1, SVT terminated.
The arrhythmia stops.
Yes. If the tachycardia completely stops, it very strongly suggests the arrhythmia is AV nodal dependent, like AV-NRT or AVRT, where the AV node is essential to the circuit. Blocking it breaks the loop, resets the heart.
Makes sense.
The source notes those exceptions. Adenosine-sensitive focal ATs or fascicular VT can sometimes terminate too. So termination strongly points to AV nodal dependence, but doesn't 100% rule out these specific others without more info. If termination occurs with an inadequate dose, the diagnosis is less clear.
Okay. What's the other main outcome?
Outcome 2. SVT slows no effect, but atrial rate continues with AV block. This is perhaps the most diagnostically powerful outcome for non-AV nodal dependent SVTs.
What does that mean?
The heart rate might visibly slow because fewer atrial impulses get through the blocked AV node, or it might not change much. But critically, you observe clear AV block while the underlying rapid atrial activity continues unchanged and visibly on the ECG.
The atrial rhythm keeps going despite the block.
Precisely. This tells you definitively that the AV node is not an active, integral part of the tachycardia circuit. It's just a passive filter for a rapid rhythm originating elsewhere in the atria.
So what are the possibilities then?
The possibilities, now clearly unmasked by the AV block, include sinus tachycardia, junctional tachycardia, atrial flutter, where the sawtooth waves become beautifully clear, or atrial tachycardia, revealing the specific atrial P waves.
So the response to AV block is a crucial real-time diagnostic test.
Absolutely. It's like a stress test specifically for the AV node. It provides critical, often unambiguous information about where the arrhythmia circuit is or isn't, guiding the clinician to the precise diagnosis and next steps. A perfect example of how physiological responses reveal underlying electrophysiology.
We've covered the intricate mechanisms, diverse symptoms, meticulous diagnostic pathways, critical initial treatments. It's a lot. So, taking a step back, what's the overall picture for prognosis for patients with SVTs? And how are these arrhythmias generally associated with other underlying heart conditions? Let's put this technical detail into broader clinical context.
That's an important synthesis. A key, often reassuring takeaway is that paroxysmal SVT, PSVT, those sudden on-off episodes like AV-NRT or AVRT, is most commonly encountered in patients who generally do not have structural heart disease.
So often in otherwise healthy hearts.
Often, yes, which is generally good news. While episodes can be alarming, the underlying heart structure is typically normal. This usually means the long-term prognosis for life-threatening events is excellent, and a cure via catheter ablation is frequently highly effective and safe. It's often a localized electrical quirk.
Okay, but what about other SVTs, like AFib?
Other supraventricular arrhythmias, particularly atrial fibrillation, are much more frequently associated with a variety of underlying heart diseases.
Such as?
Things like hypertension, valvular heart disease, heart failure, coronary artery disease. This strong association means when a patient presents with these types of SVTs, the clinician has a dual responsibility
Manage the arrhythmia.
and perform a thorough initial evaluation history physical exam to actively assess for any possible underlying heart disease.
Look for the root cause or associated problem.
Exactly. If any abnormal findings are present, a murmur, signs of fluid overload, abnormal chest x-ray, it warrants further, deeper cardiac evaluation. Maybe an echo, stress tests, specialist consultations, to ensure the arrhythmia isn't just a symptom of a more pervasive, serious cardiac problem needing its own management.
Got it. So the type of SVT gives clues about potential underlying issues.
It often does, and it's worth noting while Chapter 246 gives us this foundation and initial management, the comprehensive long-term treatment options, pharmacologic, meaning medications, and procedurals, like catheter ablation, are detailed further in subsequent chapters.
All right, this chapter sets the stage. Okay,
Mm.
so given all this intricate detail we've unpacked, what does this all mean for you, our listener, who wants to truly grasp this information with expert clarity? How do we integrate all these details into a coherent, actionable understanding?
For you, our well-informed listener, truly understanding SVTs isn't just about memorizing types or definitions, or even the steps in an algorithm. It's about connecting the dots across the entire spectrum.
Seeing the whole picture.
Exactly. Grasping how the specific, minute electrical mechanics, reentry circuits, focal hotspots, accessory pathways directly give rise to the varied symptoms patients experience. Understanding how those symptoms translate into precise, observable ECG findings that guide diagnosis. Recognizing how immediate interventions like vagal maneuvers or adenosine cleverly leverage those very electrical mechanisms to break the arrhythmia. And finally, seeing how all this foundational knowledge ultimately feeds into long-term management strategies, meticulously tailored to both the specific SVT type and any underlying heart disease. This integrated understanding empowers you to appreciate the elegance of cardiac diagnosis and the impact of targeted treatment far beyond surface-level knowledge. It's seeing the connections from the electrical impulse right through to the patient's lived experience. Hashtag tag outro.
We've certainly embarked on a comprehensive deep dive today, really uncovering the fascinating complexities of supraventricular tachyarrhythmias.
We covered a lot of ground.
From understanding their narrow QRS signatures and that critical distinction from wider rhythms, to tracing the intricate reentrant and focal pathways, and appreciating the impact of everything from a simple vagal maneuver to adenosine. We've really explored what it means to grasp these conditions like an expert.
And we've seen how a detailed ECG truly serves as a roadmap to diagnosis, and how even everyday consumer devices like smartwatches are starting to play a significant role empowering patients with crucial diagnostic data. It's subtly but profoundly shifting things.
Absolutely. So what does this all mean for you, our well-informed listener? We encourage you to keep asking those probing questions, keep connecting these dots, and keep seeking that deeper understanding, whatever field you're exploring.
And maybe for a final provocative thought to leave you with, given the increasing sophistication of wearable technology and, frankly, artificial intelligence in interpreting complex physiological data, how might the initial diagnosis and maybe even the home management of SVTs evolve in the next decade?
AI diagnostics.
Could AI-driven diagnostics identify subtle patterns, maybe predict episodes even before symptoms arise? What new questions does this burgeoning field open up for you as you continue to learn and navigate a world increasingly rich with personalized health information?
A lot to consider there. That's a powerful thought to leave with. Thank you for joining us on this deep dive.